So good afternoon, everyone, and very warm welcome to this session on ultrasound renal denervation, sponsored by Recor Medical. My name is Felix Mahfoud, and I'll be moderating that session today. What we want to do is actually we want to review the latest clinical evidence, guidelines, and technologies available for renal denervation. You'll hear a lot about ultrasound renal denervation, and you see also how to practically use ultrasound renal denervation in your cath lab. But a major focus, I think, of the whole PCR program on renal denervation is now on implementation of this technology in the armamentarium of antihypertensive approaches, which is, supported by guidelines and clinical evidence, indeed. And we want also to share best practice on how to integrate renal denervation in your institution, in your pathway for hypertension care individually. We have an esteemed panel today, all with great experience in renal denervation. Professor R.J. Kirtany from the US, Professor Philip Lurz from Mainz in Germany, Professor Flavio Ribichini from Verona in Italy, and Dr. Abu Daka from the United Arab Emirates. We hear the latest evidence first on ultrasound renal denervation, then we'll show you a case in a box, a case experience from Verona and from the UAE, and then we'll have a roundtable discussion where we will try to address all questions that you have related to renal denervation. So without any further ado, I'd like to show you that slide just very briefly as a teaser, right? So we're changing the tone now. Denervation is no longer a research tool, and I've said that before in a different session. It's supported by guidelines, it's approved by regulatory bodies, so it has to be used and implemented now by us in clinical practice, and that's what it is about, establishing denervation alongside with lifestyle modification and antihypertensive drugs in certain patients with uncontrolled high blood pressure. So I'll ask Flavio now to take over and to start the discussion on the latest evidence.
Yes, thank you, Felix. This first part will be dedicated to exchange ideas and opinions to our super experts. You have done more than 100 of procedures, each of you. So we want to know exactly what you think of the therapy. I will start with you, Philip. You have done many cases, and what is the clinical evidence on which the ultrasound-based therapy is based?
It's yours. That's mine.
It's yours, isn't it?
That's
okay.
Okay, because in the
Obviously we both could have answered it.
Yeah.
AJ is doing it much better.
Now, one thing I will say, though, about the 100 thing, is that I most certainly have not done 100 renal denervation cases, because in the U.S. it's not been approved, and so it's only been through studies. I also have a theory that if you ask an interventionalist how many cases he or she has done, the answer you get needs to be divided by the size of the ego of the person who's answering the question. So that's just a universal rule with interventional cardiology. So hopefully I'm honest, so that's why I told you I haven't done more than 100. To speak a little bit about the clinical evidence of ultrasound renal denervation, there have been a number of studies that have accumulated over the past 10 years or so, and they start with randomized sham-controlled trials, and that's Radiance Solo, Radiance 2, and Radiance HTN Trio. But there are other programs as well. So Joost Steeman and his team with the ACHIEVE studies. There have been studies in Korea. There's ongoing studies in Japan. And then there's studies led by Felix in Europe and Naomi Fisher in the United States, the Global Paradise Registry, which is an ongoing registry accruing patients over time. There are also additional indications that are being studied beyond hypertension, atrial fibrillation, heart failure, and beyond. And so at this point, we've started to amass a fair amount of evidence, and I'll largely frame my comments in the beginning on the randomized sham-controlled evidence to date. The unifying principle of Radiance HTN Solo, Trio, and Radiance 2 was that we really wanted to establish a stable baseline of medications, either off medicines entirely in 2 of the studies, and in the third study, Radiance HTN Trio, a stable baseline of a triple combination pill. The idea here is that in order to isolate the effect of renal denervation compared with a sham, if medicines are moving up and down and medicines lower blood pressure, it becomes much more hard to discern the true signal of denervation from the rest of the noise, which is medications moving. And so in SOLO and RADIANCE 2, what we did is we took patients off their medications, confirmed that they were truly hypertensive after that time point, and then randomly assigned them to renal denervation versus sham. In RADIANCE Trio, patients had more severe hypertension, so they couldn't be taken off their medicine safely. They were all transitioned to a single combination pill of an ARB, amlodipine, and a thiazide diuretic. If they were stably on that medicine with elevated blood pressure, they could then be randomized. What was interesting is there were patients in RADIANCE Trio who were on the exact same doses of 3 separate medications and uncontrolled, and yet when treated with a single pill of the exact same doses of 3 medications, they were controlled. So that's a learning point, I think, for all of us when it comes to management of these patients. They were assessed for anatomic eligibility, so that was done routinely within the trials. They came to the cath lab, had full blinders on, and were randomized to denervation versus a sham procedure. For follow-up, they were followed up by teams that were blinded to the treatment assignment, and in addition, medication changes were not permitted unless they were needed on the grounds of escape. And at the 2-month endpoint, we repeated ambulatory blood pressure monitoring to discern the difference between baseline and then. And what we showed is that across all 3 studies, there was a consistent reduction in blood pressure with ultrasound-based renal denervation relative to the sham procedure. One thing you'll also note is that, like other off-med studies, the change from baseline is minimal because the patients are off medications in the sham arm. And in the patients who are on medications, you always see a greater change in the sham arm with that sham with on-med studies. And the reason for that is because there's always medication intake that's changing, and you see this across all programs in the renal denervation space. The absolute difference relative to sham was on average approximately 5 to 6 millimeters of mercury in daytime ambulatory systolic blood pressure. The change in baseline, which is what a clinician is actually going to see when they treat patients, because there's no sham in terms of clinical practice, is approximately 8 to 10 millimeters of mercury in daytime ambulatory systolic blood pressure, which means for office blood pressure it's likely going to be greater. If we look at other measures of blood pressure, whether it's daytime, nighttime, overall ambulatory, home and office, you see commensurate reductions in blood pressure, greater with renal denervation, minimal changes with the sham across these studies. So what's new in terms of the renal denervation space, ultrasound-based renal denervation? There are a couple studies that were presented here earlier this morning in a poster session. Andrew Sharp presented this data looking at patients that were initially randomized to sham who remained hypertensive, who then were allowed to cross over and be treated with renal denervation. And what we see are decreases reproducible after the crossover to the renal denervation procedure. This was seen with daytime ambulatory and office. One of the things I'll definitely point out with this is that you can say, well, why is the ambulatory difference greater than that of the office? Doesn't office usually reflect a greater change than ambulatory? Yes, generally it does, except when the design of the study is such that patients come in for their office visit based on what they're doing at home. In the office visit, after blood pressure is measured, they're given the medicines that were prescribed under directly observed therapy, and then go back home with their ambulatory blood pressure. And so in a sense, what's happening is the ambulatory pressure is reflective of medications plus the effect of denervation, whereas the office blood pressure just reflects what they're doing at home, which is variable adherence. I also presented in the same session a predictors analysis. These are looking at patients that were treated with renal denervation across the 3 studies and looking at what things might predict a greater response. What the things that predicted a greater response were, number 1, starting off higher. For every 10 millimeter higher your blood pressure started in terms of daytime ambulatory systolic blood pressure, you had a 2 millimeters more greater drop in blood pressure. And then if you started off with orthostatic hypertension, in other words, you stood up and your blood pressure went up by 20 points or more, then you actually had a 6 millimeter more reduction in terms of blood pressure with renal denervation. What about durability? This is always asked, and certainly in the ultrasound space with the Record device, there are less data than, for instance, the Global Simplicity Registry when RF came out. But are there durability data with this device beyond what was presented at the FDA panel, which is typically data out to a year? There actually are. So we've shown and published data from the SOLO trial. These were patients that were initially off meds, and we looked at what their change in blood pressure at baseline was to what it was at later follow-up time points. And in general, blood pressure remains lower. I will say that there's a caveat with all the durability data where you see the ends are not always the same at the long-term follow-up as they are initially. And so there's some loss of the cohort there. But in general, despite medications being, and the reason we present baseline is that these patients were taken off meds. So at 2 months, the reason the med burden is 0.1 is because they were off meds. Some of them had to go back on meds. So overall, their change in medications from baseline when they entered the trial was no different, and yet their blood pressure was appreciably lower within this study. Similarly, in the TRIO trial, these are patients that had elevated blood pressure despite being on medications. Their blood pressures got lower after denervation, and out to 3 years, you can appreciate that there's consistent decreases in low overall blood pressure as measured in this way without an appreciable increase in medication burden. And then finally, data from the ACHIEVE registry shows that basically we see similar results, durable effects over time with these with this device specifically, and not real changes in medication burden as a whole. So to summarize, what does the data show us with ultrasound renal denervation? It shows that in sham-controlled studies, there's a clear difference between denervation versus a sham procedure. It shows that that difference, when extended out to registry studies and also extended follow-up from those trials, does appear to be durable over time. And I think that's one of the reasons why we've titled this session as the third pillar for hypertension treatment, because the feeling is that if you have patients that have uncontrolled blood pressure and you've tried everything else and they failed, i.e. lifestyle modification and medications, then this represents a data-driven approach to treat those patients, not something that perhaps a year ago or 2 years ago was thought to be more of a potential future technology or a science experiment or something like that. Thanks so much for listening, and happy to take questions, and I'll go on to Philip as well.
We will make the questions later. Now, yes, Philippe, now it's your turn. And show us your experience and the comparison between systems.
So, yes, thank you. So in the next 5 minutes, I would like to discuss with you a little bit about what we're trying to achieve with the therapy, what technology we need, what are the requirements for the system, and how can we get the best outcome, obviously. And to do so, we have to appreciate first what is the problem and what are we trying to do. Obviously, we try to approach the sympathetic nerves, which are in close proximity to the renal arteries, because they contribute to a hyperactive sympathetic system, and the reduction of sympathetic drive can lower blood pressure. And I think this is one of the most significant and important contributions to the entire field of renal denervation, because it shows three things. First, it clearly demonstrates that the sympathetic nerves, they are located at all aspects of the renal arteries, so superior, inferior, anterior, and posterior. Meaning that if you want to be efficient and really reduce sympathetic drive, you need a technology which allows you to treat and apply energy circumferentially. The second thing, what it shows is how far are these nerves away from the lumen of the renal artery. And obviously this follows a certain distribution, but the vast majority of sympathetic nerves, they are located up to 6 millimeters away from the lumen. And then the third aspect, which was shown, is that they're in closer proximity to the renal arteries the further you go distally, and they're even closer when you go into the branches. So that means that the technology applied ideally needs to be circular, circumferential, needs to apply and emit and transfer energy in a 360-degree fashion, and it needs a certain penetration depth to be in reach of most of these nerves, and depending on your penetration depth, then you either stay in the main renal artery or you also go to the branches. Now this is a model of how ultrasound denervation works. You see that with the transducer being right centered in the vessel, and the centering of that transducer that is enabled by the balloon which is around the transducer, and then the energy is emitted in a 360-degree fashion, 7 seconds of sonication with a calculated and estimated penetration depth of 6 millimeter. Obviously there are different approaches and discussions. Where should you apply the energy? Can you stay in the main arteries, or do you have to go to the branch arteries? But thinking about that we want to have it circumferential and we need a penetration depth of 6 millimeter, it is fair to assume that applying 2 to 3 sonifications in the main renal artery, the vast majority of renal nerves should be within reach. So, and then the last aspect, I said that the transducer is surrounded by a balloon, and the balloon is inflated, which allows to center the transducer right in the middle of the vessel. But in addition to that, the balloon is filled with water, which provides some cooling and thereby helps to preserve the endothelium, which obviously should not be harmed by the sonification. So in summary, ultrasound denervation is a modality which is speedy and should have the appropriate and sufficient penetration depth. It allows you to stay within the main renal artery by applying 2 to 3 sonifications, and the cooling helps to preserve the endothelium. Are there any data to support that approach? Because as said, there's always and still ongoing discussion, where should you apply the energy? Can you stay in the main renal artery? Should you go more distally? Should you go to the branches? A while ago, we performed a study called the RadioSound study. That was a head-to-head comparison of 3 different approaches. One approach was staying in the main renal artery using ultrasound. Second approach was using radiofrequency, only applying energy in the main renal artery. And then the third approach was radiofrequency, but applying energy both in the main renal artery but also in the branches. In total, 120 patients were randomized, 3 groups. Endpoint was change in daytime ABPM systolic at 3 months. And that's the summary of what we found. We saw the most pronounced drop in systolic daytime ABPM, blood pressure drop from baseline to 3 months in the ultrasound group. We saw an intermediate blood pressure reduction in the group of radiofrequency and energy delivered both to the main renal artery and the branches. And then we saw the lowest drop in blood pressure in the group with radiofrequency and staying in the main branch only, and that the difference between ultrasound and radiofrequency main only was significant. Now, obviously, when you have to apply less energy at less positions, then the procedure is a little bit faster and it requires less contrast, volume and fluoroscopy as shown on the right-hand side. And then in addition to what AJ said already, longevity, well, we still need to follow up. We still have to gather and combine and pool more data. This is a single cohort analysis from the Leipzig experience. And there you see that the initial blood pressure reduction seen at 3 months was well maintained throughout a follow-up of 2 years. So that's in line to what we've normally seen. We don't see an increase in blood pressure with that technology during follow-up, with the obvious limitations that some had more blood pressure medication, some had less, and obviously, as always, the nature of these registries, you have patients who drop out. Thank you.
Thank you very much. So these are the data, and these data need to be discussed, I guess. Are there any questions? There's a question, yes? No? No question. Okay, I'll start. Ajay, when you look at the data now, do you feel that something is missing, or are you satisfied with what you have achieved in that program, which is showing that denervation works in the presence and absence of antihypertensive drugs in sham-controlled trials and in real-world registries?
No, I think for me the biggest the thing that I'd like more of is longer-term data. I feel that that's so essential for everything. I also think. I mean, maybe to pivot a little bit to the procedural aspects, it is important because I don't think people necessarily understand. I mean, people can understand that two devices, especially in the United States, got approved and that they both lower blood pressure. But I do think there are significant procedural differences. And to highlight some of the points that Philip made, this is really only necessary to ablate in the main arteries to get the blood pressure effect that was achieved within the studies. And that's not the case with the competitor technology. And so that's an important differentiating feature of it. I think the other attribute of it in terms of the time, which you mentioned, is also what that means procedurally during the case. And a couple days ago, I illustrated it. When you're doing an ablation, it's not a pleasant thing for the patient to feel. And typically patients are given Versed and fentanyl. We don't give anybody propofol or general anesthesia. But when this procedure is done, the patient starts to feel it after about 2 seconds of ablation. And the difference between waiting for 5, 4, 3, 2, we're almost done, and that's it, versus continuing for another 30 seconds or more and then doing that ablation times that many more times, I think is an appreciable one for the interventionalist. And it's something that we should talk more about because it's certainly something that you experience in the cath lab.
And we'll see it in a second during the cases as well. But Philip, when you look at your long-term data, and you have started treating patients in Leipzig years ago, a decade ago almost, I guess, can you tell us a little about the long-term outcomes? Are you concerned about renal re-innervation, regrowth of nerves, and a secondary rise in blood pressure over time? Is that something you are seeing?
I mean, it has been proposed in animal models. I don't think that we have seen any clinical reflection of that phenomenon. As said, there are some limitations to looking at long-term data because you have some changes in blood pressure. But if you look specifically at our data, the number of patients who took more or less blood pressure medication was pretty equal. So it equaled each other out, and not only here, but also some other reports have shown that the initial blood pressure reduction is actually well maintained during follow-up. I'm not aware of a relevant signal suggesting that the early effect disappears over time.
Flavio, at the end, it's all about patient selection, and we'll discuss that later, I guess, also. But if you would have to summarize, and I guess you're doing it for the cases as well, what is a patient where you consider denervation being a very attractive treatment option?
Well, for sure, younger patients benefit most for avoiding lots of medications. Older patients, they need other medications, cardiovascular, prostata, pulmonary, and then they add also blood pressure pills. Young patients, sometimes they don't need that much, so I'd like to treat more young patients and less comorbid old patients. And then those with the highest blood pressure seems to be those who respond better to the therapy.
That's an important point, I guess, and something that we have to keep in mind, though, is that most of the patients still require medication post-procedure, right? And Ajay, you have run an analysis looking into the Radiance program. Tell us a little how many patients in the SOLO trial were kept off medication long-term, and how many patients were put back on medication to achieve target blood pressure control?
The rate of being controlled off medications is exceedingly low. And actually, if you look at the rates of control overall, you would think that if you take patients and you treat them with renal denervation, that everybody ought to be controlled. And that's actually not the case. And so people do require medicines to be controlled. It's far greater with denervation compared to sham. So you're more likely to achieve it. But I don't typically tell patients that you're going to be able to come off your medications and achieve control. You typically will either achieve control or reduce your medicine burden.
And that's very important, right, for patient communication. And I guess we have all experienced that. You have to set expectations, what a patient can expect post-procedure. It's not that we see typically a fall in blood pressure of 30, 40, 50 millimeters of mercury in individuals, so that they are dissatisfied post-procedure. It's important that you handle these expectations pre-procedure and that you talk about what they can expect. very frankly, actually. And it's roundabout, and we can go through the panel, right? What are you consenting patients on? What's the average change in blood pressure in clinical practice a patient can expect?
You know, we tend to say about 10, which is similar to what you would be achieving with a medication. The other analysis that Felix is referring to is we did stratify patients by what their starting blood pressure was. And so if you start off high, you're more likely to achieve a greater drop in blood pressure, but you're less likely to achieve control because you're starting off that much above the control threshold. On the other hand, if you start closer to control, so if your blood pressure is 141, there's more likelihood that you're going to achieve control with that even lesser drop in blood pressure that patients see. So for me, I typically tell them, you know, we're hoping on average to expect that drop. We also do say, and David Kanzari brought this up in the last session, that if you do get a drop, because there are some non-responders, the drop is likely going to be greater, but we just don't know if you're going to be that patient.
Okay, yeah, please.
Another very important point before you proceed with your patient, you should make sure that he is not going to stop the medication. Some of them will tell you after the procedure, is it okay that if I will stop the medications? And especially those patients will come with you with multiple, like 4 or 5 classes of antihypertensives. You should be very clear, and you should tell him that we will start dropping down gradually, but you will live with medication, but less medication. And we know very well from the common practice, especially in our Middle East and North Africa area, the more you prescribe to your patient, the less he will be adherent to the medications. And cutting down, you know, the number of pills from 6 or 4 down to 2 or a single pill combinations of 3 antihypertensive, it's a big achievement. Adding the benefit of, you know, from the SPRINT trials, we know intensification of medication is really harmful to the patient. This will add a lot to the patient. So these things are supposed to be very clear to the patient that we are protecting you. Your disease is not curable, it's manageable. We will manage it much better when we do this procedure for you. Sometimes I go to the history of the renal denervation with the patient to convince them that it's not a new story, you know, started back in 40s in Boston with Smithwick, and there is a publication back in 1952 maybe, and there is a big jumps when it comes to renal denervation from, you know, dissecting down the vein, the nerves. Then we did the radio frequencies like almost 15 years back, 2009 or 2010 and 11, and now we are coming to something more safe, more effective. So it makes a big change with the patient, and he will. And this also will encourage him to be adherent to the least number of the medication after you ablate the nerves.
The other thing is the treatment effect is not immediate. So typically in the studies that have looked at it, the endpoint was measured at 2 months or 3 months or even longer, but it takes time. So you have to set that expectation right as well.
But yes, please, go to the microphone, identify yourself, please, and ask your question.
Hello, I'm Dr. Wael Abu Shokka from Qasimi Hospital. I would ask about, in your experience, have you ever redo this procedure, and what was the effect in the second procedure?
Who wants to take that? Redo procedures? Done, Philip?
Yes, I did once before.
You did one, okay, and you?
Yeah, I've done redo procedures, but not with the same technology, but with one technology first and then the second thereafter. And the second time around, there was a response in those who were initially non-responders.
But this is something for research, I guess, right? More than for clinical practice. So it has not been systematically investigated whether a second denervation in non-responders or those who have a secondary rise in blood pressure does good long-term in reducing their blood pressure. Not been investigated yet.
But it is very important things to
absolutely
have it in the pipeline for the next research.
Yeah. Before we'll dive into the cases, I want to ask the audience here, who has done renal denervation procedures? Show of hands. Okay. Who's interested in starting a program? Okay, and who has performed ultrasound renal denervation procedures? 2. Okay, so lots to discuss, I guess then. Flavio.
I mean, lot to tell them. One important point, but very quickly, what Ajay say, patient and referral should know that the effect of the therapy is not immediate. In this slide that is still there, Philips is showing that after 3 months you get a quite stable result with ultrasound. With radio frequency, it might take a little bit longer. There is a kind of laser response immediately, but there is a progressive respond at the long term. So this must be said. Patients should not stop taking pills after the procedure. Otherwise, they will be very disappointed to see their blood pressure going up.
Okay,
Okay,
let's do the case.
we do.
Yeah.
So our experience with denervation started more than 10 years ago, and it's basically performed with radio frequency. But what we want to share with you is the organization of the service of renal denervation. We should get out of this slide, but it's not. Skip. ESC. It's not working. Okay, now it's doing. So the most difficult part of a program of renal denervation is having a patient on the table. The procedure itself is very simple. Either you use the ultrasound or the radiofrequency-based system, but it takes a long time to obtain patients that are referred. You can get your first patient from your own division of cardiology, from your own outpatients clinic, but it takes a lot of time to create this faith about the therapy and the center to refer the patients. We understood that after many years of trying to organize on-site, in-person meetings to discuss cases that were totally ineffective because most colleagues were not attending this meeting. Everything changed after the pandemic when we organized these meetings on a virtual basis. I don't know if it is because of curiosity or for simplicity, but many colleagues that were not coming in person started to connect to our discussions. We are doing a monthly discussion of cases, and we have a dedicated website that can be consulted by both doctors or patients in case they want to obtain information about the therapy, and they can also access outpatients clinic in our specialized hypertension outpatients to get an appointment and get explanation of what is the therapy about. It's a multidisciplinary team that includes diabetologists, endocrinologists, nephrologists, and medical colleagues on internal medicine. So the process is quite straightforward. Of course, the first step is trying to optimize by any ways the optimal medical therapy of patients, educating them on the importance of changing diet and lifestyle, they say incremental importance of physical activity, and of course ruling out any kind of secondary hypertension. And this is mainly guided and led by our specialists on internal medicine, as I said, endocrinologists and nephrologists. Once this is not obtained, the patient is not on target. As you see, we meet regularly once a month. It's a meeting that lasts 1 hour. We discuss 4 or 5 cases, and the patients are presented to be considered for renal denervation treatment. But still, involving all the other specialists, there might be requests to go further with changes in the type of drug, the timing of the assumption of the drug, or the need for additional examinations. If the patient responds finally to medical therapy and he keeps on being on target, which means that he behaves and takes the pills, we follow these patients in our regular outpatients clinic. But if despite all these efforts the patient is not on target, either because he's really refractory or because he's not behaving and has not good patient adherence and he agrees to undergo the therapy, then the patient arrives on the table. Just to let you know, in a year we discuss about 100 patients and we put on the table about 1 out of 4. So we do more or less 25 ablations. We discuss more than 100. So it's a lot of work before. The smallest part of your job is putting the patient on the table. This is the catheter of the Paradise. It's compatible with the 7th French. It goes through a femoral access. You need dedicated guiding catheters, shorter than the coronary catheters, with the shape which is very common, is the Lima catheter. And you can use a regular coronary guide wire to navigate. The strategy of the therapy with this device is very simple. You can target just in 2 or 3 spots the main artery when there are no accessory arteries. You don't need to go distally. In case there are accessory arteries of a diameter bigger than 3 millimeters, it is recommended to perform at least 1 ablation in the secondary artery. So this is a case of nice patients. These are not very frequent. As I said, the first patients you will get are those coming to the hospital because they have other problems. They come because of an acute infarction with stable angina, so they have comorbidities. They are diabetics, they have CKD. This is a 54-year-old lady with a 10 years history of hypertension without clinical events. And you see, we tried for 2 years to put her on target, and it was, as I showed you before, discussions, changing the pills, changing the timing of the assumption of the therapy, but she was not on target. She has initial LV hypertrophy, which is very clear both in the ACG and the echo, and an initial retinopathy grade 2. So, of course, secondarism must be ruled out, and this is the job of our colleagues. They help us on that, even because they trust more on their own examination than those that you do as a cardiologist. This should be said. You see that the therapy is complete and respectful of the current guidelines. An inhibitor of aldosterone is always included in patients. This is always recommended. We assess for adherence, and the patient's husband was saying that lady was taking effectively the pills in the morning, in the afternoon, and the cardiovascular risk factors, of course, she didn't have events, but she's at high risk of events, and the patient agreed to undergo the procedure. We always perform ambulatory blood pressure measurements, and as you can see, despite the intense medical therapy, the blood pressure was severely elevated, both in office measurements, but also in the ambulatory blood pressure measurement under blood therapy. So the first thing we recommend to do, it's a non-selective angiogram with a pigtail placed more or less at the height of lumbar 1, lumbar 2 in subtraction angiography, which means not more than 10 or 15 cc's of contrast to see where is the origin of the arteries. You can see then it follows with a selective injection. It's very important that you see the shade of the kidney to understand whether this artery is providing flow and contrast to all the parenchyma, which is clear on the right kidney. It's not so clear on the left because there is an inferior pole that probably is missing. Then it's very important that you size your balloon according to the size of the artery. It should be same size 1:1 or a little bit bigger, not smaller, to avoid flow distally and to have a good contact to the artery wall. QCA is recommended. I mean, it's not coronary analysis, but the artery analysis, quantitative analysis, is recommended to be precise. You see that on the right, the artery has a little bit more than 5 millimeters of diameter and less than 6. The left artery, it's a little bit smaller. It's in between 4 and 5 millimeters. So we decided to use 2 different balloons. This is how it works. You can advance the guide wire. We recommend to use non-hydrophilic wires. The catheters advance easily distally, and you start with the distal ablation, which, as Ajay said, lungs for 7 seconds, although this is also very painful. We don't make a difference in the pain management. Either we use radio frequency or ultrasounds. I mean, it's painful. We go very, let's say, intensive medication so that the patient experience no pain and he has no memories of this bad experience. You see that you check that the arteries are totally occluded, and 7 seconds, and the ablations is performed first on the right kidney, same thing on the left. The procedure is very simple for an expert interventionalist. I think that the most important thing is to find out where the arteries are, because of course are different anatomic differences, and to spare useless contrast. This is why we advise to perform a non-selective angiogram of the aorta before going with the selective catheter. The total procedure time in this case was about 50 minutes from the puncture to the closure. We use normally a dedicated device to close with AngioSeal or ProGlide. The total contrast media used in a renal denervation procedure must be below 100 cc. You can do even less than that. In this case was 70 millimeters. It was the first procedure we did with this system, so I think we can do even better. The total fluoroscopy time is minimum because you don't need to navigate distally into the artery, just in the main artery. We use an A-French guiding catheter. I think there is a difference in between the Cordis and the Medtronic. The lumen is different, so we wanted to be sure. We had a Cordis catheter which has a smaller lumen. We went with 8 French, but I think that most 7 will fit. the catheter. We do preventive hydration anyway. I mean, water is free, it's good, and so we normally treat patients with pre- and post-procedural hydration. And she was discharged the day after 30 hours in the hospital. And we have 6-month follow-up of the blood pressure measurement in ambulatory blood pressure. You see there is a significant reduction of a mean of 170 to 120, both systolic and diastolic. And then we got recently 1-year follow-up of the kidney function. This is something we see, the better kidney function when you have much better blood pressure control. And this is with the additional advantage, which was reducing one medication in 6 months. Thank you.
Thank you, Flavio. I think we directly continue with the next presentation and then discuss both cases together.
So I got you a totally different patient, a unique patient when it comes to refractory or resistant hypertension. This patient was referred to my clinic for coronary angiography by our hypertension clinic or the internist at the hospital. I don't have any potential conflict of interest. I am representing Al-Qasimi Hospital. This is the first ultrasound, RDN case done on the Middle East and North Africa. Here you are, the team, under the supervision of our head of the department, Dr. Arif al-Nouriani. Everyone was there, even our cardiac anesthesia, because as Professor Flavio said, it's a little bit painful. You may need conscious sedations. So my patient, as I told you, he's a different patient. He's a 60 years old male patient, and he is hypertensive for the last 13 years. He's also diabetic for the last 5 years, dyslipidemic, heavy smoker, not even a normal smoker. He's a really heavy smoker. He jogged daily for an hour. He is really adherent to his medications. And here you are, his antihypertensive at home. He's in beta blocker, nebivolol, 5 milligram, and he's in single pill combinations of perindopril, indapamide, and amlodipine, 10 milligram, 2.5, and another 10 milligram of amlodipine, moxonidine 0.4, and he is also in methyl dopa 250 milligram thrice daily. These medication were, prescribed by his internist. So he came to my clinic and he's supposed to go for angiography, but when I got the history from him, his pain is atypical, so I sent him to coronary CT angio, which was negative. Even the calcium was not that much high, the calcium score. His ECG, sinus rhythm, left ventricular hypertrophy with a strain pattern. His echo showed a good left ventricular systolic function with mild concentric LVH and grade 2 diastolic dysfunction. Already he is ruled out, secondary hypertension by hormonal profiles. They did all the investigations, but we make sure that his hemoglobin is stable, his eGFR is fine, his hemoglobin A1C also is controlled, and his LDL cholesterol is acceptable. We did an ambulatory blood pressure 24 hours, and the average readings, despite being on all these medications, 6 class of antihypertensive, was 145/90 millimeter of mercury. So, what was the plan? Here you are, his ambulatory blood pressure. Instead of doing coronary angiography for him, I convinced him to go for renal artery denervation. So he was really a little bit shocked. He said, I came here to look after my coronaries, and you still want to do another procedure for me. He's a really understanding patient, and he likes the idea. He Googled it, by the way, and he came back to me, and we performed for him the ultrasound renal denervations. These my tools and my axes. We went, as Professor Flavio said, right femoral artery, 8 French sheath. We used the Visibac, 100 ml mixed, like diluted, like 50-50. And anticoagulant, as a usual procedure, you go femoral, we give 8,000 international units. We use the big tail just to see where is the renals. We use also the high torque BMW universal wire. We use also the double curve catheter, 7 French, 65 centimeter to cannulate the renal arteries. And of course, after we finish, we choose the AngioSeal VIP to, close the access sites. We use 2 sides of the balloons, but I will tell you why now. Here you are, the anatomy of the renals, the descending abdominal aorta. As you can see, there is no stenosis. We performed a QCA to, choose the size. Sometimes we use the wire to help us cannulating the renal arteries if the angulation is not that much proper, or if we face a difficulty, we use the wire to cannulate. Here is the left main renal artery, and we found also an accessory renal artery at the left side. And both are of a very good size. When you do have an accessory of 3 or more, you must ablate it at least once on like sonication, as Professor Felix said. And here you are, the right renal artery angiograph. So we started our procedure with 4.2 balloon. Unfortunately, it was not well opposed to the wall. It is very important to choose a balloon 1-to-1 size or more. You do have a very good oppositions to the wall for a very important points. Not only the delivery of ultrasound, the cooling system, as mentioned earlier. The cooling system is something very, very important, not to harm the endothelium. Okay, so when you do have a balloon opposed in a very good way to the wall, you have better cooling, you have better delivery of the ultrasounds. So we start with the 4.2. Unfortunately, it was not enough, so we moved to the 5 balloon. And as you can see, this is the position number 1. We start distal, coming proximals, and here you are, the positions number 2. I call it occlusive, or like opposing. And this is the 3rd position proximally. All these are on the accessory left renal artery. So 3 sonications were performed. We moved then to the left main renal artery. Again, the same balloon was used, distal, mid, and proximal. And here you are, the control angiography after ablations. You may notice some irregularities, but it's not like what we saw before with the radio frequencies. And this is due to the energy delivery, it's heat. During the procedure, the patient was under conscious sedations by our cardiac anesthesia. So we moved to the right renal artery. Again, we used the same balloon, and we performed 3 sonications in the 3 positions, distal, mid, and proximal. So, total 9 sonications, 2 balloons used. We used only the 5, but that one was open, but was not, opposing. The procedure time was a little bit longer than the average time. It was 62 minutes because we do have 3, vessels and total 9 sonications. I was not happy with the methyl dopa, and next day morning his blood pressure was fine. This patient, he's really aware about his blood pressure. He said, I will not, have a blood pressure less than 130/80 despite being on all these medications. So I stopped his methyl dopa, and I called him back after 8 days to my clinic with a repeat, ambulatory blood pressure. I repeated the ambulatory blood pressure earlier because the patients called me and he said, my readings are really low. I was a little bit shocked because, as we see, you have to wait at least for a month, 2 months to find a result for the sound ablations. So what I said, okay, come, we will put the ambulatory blood pressure and we will see. Maybe your device is not that much good. And I was really shocked about the result. Here you are. This is after almost 7 days or 8 days of the procedure. So I stopped his moxonidine that time. Until now, he's on single pill combinations of the perindopril, indapamide, and amlodipines, plus the nipivilol. I called him 2 weeks before I come here to repeat the ambulatory. He said, I don't want something to keep pressing. I am assuring you that my blood pressure is almost always at 120/80s. Thank you.
Excellent. Excellent. So please join us back here, and we want to discuss the cases. Do you have questions? Is that a question?
So while we're waiting for folks to, maybe? No, leaving. Okay. I was just going to say a couple procedural points that are of note and important. So Flavio made the point about the guide compatibility, and it's true. I think the key is this is a 7 French procedure with a 7 French large guide. Radio frequency is 6 French. Ultimately, these will all go transradial, but for now, that there is a differentiating feature, and the specific guide you use may make a difference. You can do it through a Cordis guide, but it's tight, and so if you don't use diluted contrast, you may get an error with the cooling balloon. It can be troubleshot, but that's one of the reasons why I think Flavio uses, we used 8 in that case, or you can use a 7 Medtronic guide. The second thing is that you wonder, with that quick ablation time, why is the procedure 60 minutes? And there is a prep time for the balloon. So when the balloon has to have the cooling go through and then come back and make sure everything's okay. And so while these are faster procedures in general, there still is, if you're an interventionalist and you like to move fast, and you can see I'm a New Yorker, I talk fast, I move fast, that cooling prep step does take time, and you may have to use multiple balloons, which is different than other technologies. Other technologies is a single catheter spiral, for instance, that you just go in with. So there are differences between the procedural aspects of these cases, and some of it's good and some of it's not so good.
What do you do in very inferior steep offtakes? And in one of your cases, I think on the left there was a steep offtake. What do you do in those circumstances? And you know the catheter tip can sometimes flip out. So what do you do?
This would be ideal for a radial access, but we don't have. Well, most of the times we use a balanced heavyweight, which is a very benign wire that gives excellent support. And of course, for a coronary operator, is not an issue to push this catheter into the renal arteries.
What about manual modification of the catheter angulation?
Manual?
Yeah.
No, I don't do that.
Yeah, I would be a little concerned. I mean, I showed a case a couple days ago where it was literally a vertical up-down, and even the wiring with a conventional wire was difficult. And so I actually used a technique where I took a hydrophilic wire, and I completely agree with the points. We don't want to cause a distal wire perf in any of these cases, but I took a hydrophilic wire to defeat the friction, took a microcatheter, swapped the wire out, put a support wire in with the loop on the end of it, and then actually the balloon tracked without any issues. But you do have to, use standard techniques in these more difficult
Standard
cases.
techniques means that you can put two wires to help to go with the catheter, and then you retrieve the side wire as with the coronary.
Especially in the 8 French. Yeah.
Philip, what do you do in Mainz, and what have you done in Leipzig with post-procedural anticoagulation, like DAPT, APT, or nothing?
Those who haven't had an indication for anticoagulation for some other reasons, we kept them on dual platelet for 3 months.
Okay. So we do 4 weeks, DAPT, and then aspirin mono in most circumstances, if there's no other indication. But there are, in the Radiance trial, there was nothing
Yeah,
recommended.
we would do an
right?
aspirin alone.
Yeah. So it's evidence free, right? But I think in most circumstances you can come along with aspirin mono. That should be sufficient. There's a question here from the audience of sizing the balloon appropriately. Is there any role of using CT beforehand to determine balloon size during the procedure?
That was what was done in the trial. So the CT was done, and it was actually great. The measurements would come back with a three-dimensional, reconstructed image. I will say, though, it's sometimes discrepant with what you'll see in the actual procedure itself, whether that's via QVA calibrated to the catheter or even by intravascular ultrasound. We don't do IVUS routinely. At Columbia, as most people know, for coronaries, we use it 90+% of cases, so we have a very low threshold to use it. But for sizing purposes alone, it's not necessary to do. But the CT can be very helpful. And the CT is also super helpful for identifying accessories. I think that one you showed with the left accessory, I'm not certain people would have necessarily picked that up based upon the angiogram.
Is there a limit number, or a maximum number, maximum number of ultrasound emissions per balloon? So how many emissions can I do per balloon?
I don't know the
Is
answer to
that
that.
chipped?
Anyone
Is that
from
chipped?
RECOR here
From
who can
RECOR?
answer that? Yeah.
Is that chipped? No, I don't think so,
Yeah.
right? You can use as many, you can emit as many as you want, right? Okay. So you did 9?
Yes.
Okay. So that worked, obviously. So no limitation there.
And still you can see, the endothelium irregularities.
Go ahead.
This means there's a heat. You can still see when you perform a controlled angio post-ablation that still there's some irregularities. This means the heat's still there. And what good about this, as mentioned at the talk, that the heat can dive deep up to 1 to 6 millimeter. 70 to 75% of, these afferent and efferent nerves in advantia, it's only 2 or 2.5 millimeter. So still, the heat will reach these, nerves and ablating them.
Felix, you want to comment on that? It seems to me if you're going to only do the main, you better go deep and as circumferential as you can. Is that like a simplified version of of
Yeah.
what you've observed?
I think circumferentiality is probably the most important aspect of it. It's not penetration depth alone, it's the circumferentiality and taking into account that you have heat sinks and heat tanks located in the adventitia that may change the ablation pattern. So circumferentiality is probably the most important aspect here. Another question, and this refers to you, Philip, rate of responders in the radiosound trial. You recap?
He has to think back.
Yeah, I'll have to think. I think it was
Or
it
tell us what's your clinical practice. That's probably the same.
So it's about 70%. I think it went up more to 78% recently. Interestingly, the responder rate was comparable between the three groups. There's another point of discussion. What's more important, response or magnitude of response? But then it comes down to definition of response. And if you define it with 5 millimeters of mercury blood pressure drop, and then you have a patient with 4.9, he's a non-responder.
Yeah.
Does that make sense? So I think it gives us a rough idea of the responder rate in general, but it might not always be the right thing to judge individual patients.
Good answer. Flavio, you have used various systems, RF and ultrasound, and here's a question for you then. The scale of pain, is that different between ultrasound renal denervation and RF ablation, and do you use different protocols for anesthesia/sedation?
No, I mean, it's clear that the pain lasts longer with radiofrequency. This is shorter, but the intensity is the same. And what you really need is two things. First, that the patient is not moving, because when you have a balloon inflated, it's not good that he moves, may create dissections. When you use radiofrequency, if it moves, the electrodes lose contact and you have to repeat the procedure. And the second thing is that the patient does not remember. So you need something that creates amnesia. And this is why, in the end, you use the same drugs. I mean, we do the same
So no difference.
protocol.
Okay.
No difference.
What do you do if you find significant atherosclerosis during angiography? That's a very good one from Mateusz asking that question. So I think you mean a relevant renal artery stenosis, right? That has been detected
Or
then
just
for the
plaque,
first
or
time.
just plaque at all.
I can address that. We have published, because this happens when you have these multidisciplinary teams and you rule out secondarism, it happens that stenosis may not be detected properly. What we do is putting a pressure wire on the artery. If the PDPA ratio is over 0.90, it is very, very unlikely that this stenosis creates ischemia and therefore a secondarism. If the PDPA is below 0.90, it's very likely that this kidney is ischemic and the hypertension is secondary. So we take the decision on that basis. If we get PDPA below 0.90, we put a stent and then we reevaluate the patient. You can still denervate the patient after endothelialization of the stent 6 months or 1 year later. If the PDPA, despite stenosis looking ugly, more than 50%, the PDPA is normal, we proceed with denervation. We will publish, we have more than 10 cases like this. We are waiting for the follow-up because, of course, these patients have atherosclerosis. So the point is not only blood pressure, is progression of filtration rate.
In poor countries like Germany, you can also use it's just a guide, right? Put the guide distal or catheter distal to the stenosis, pull it back, and see whether there's a 10% difference in gradient between the two post and pre-stenotic measurements. And if that's the case, very likely you have a significant renal artery stenosis.
Would you ablate at the site of plaque, though, or do you avoid
No.
that site?
We avoid exactly the plaque. You go distally. Yeah.
Yeah, so what we do in that case, and that was a case I showed a couple days ago, is I IVUS, and if the plaque is significant there, then I would avoid that site, but then you also want to determine the hemodynamic significance of it potentially if it's renovascular.
Another question refers to guide extension catheters to deliver the balloon distally. Has that ever been required in one of your cases, your experience, any problems with deliverability of the balloon?
I haven't, and the case that I showed, I thought I was going to have a problem, but I didn't. The only challenge with guide extension is, remember, you need an OD that's 0.78. And so you need a guide extension that could do that. So honestly, it would have to be sort of almost like a telescoping guide within guide rather than a guide extension, unless you took an 8 French guide extension.
Last question, probably to Philip. What about new indications beyond hypertension, atrial fibrillation, heart failure, chronic kidney disease. Any final comments there?
All of those suggested for a long time. Now we've solved the problem of creating evidence for arterial hypertension. I think we can now solve the next problem and do the studies in all of these indications. But I think the role of reducing sympathetic drive goes obviously way beyond just treating arterial hypertension.
So that was a nice outlook into the future, into the near future, very hopefully. I think you've heard today that this is really should be part of clinical practice. We see patients with uncontrolled high blood pressure who are in need of alternative approaches. Renal denervation is one of those alternative approaches. Ultrasound renal denervation is one of the approved devices available that comes with a lot of evidence and approval by the US Food and Drug Administration. It's commercially available in Europe and many geographies around the world. Consider it as a treatment approach in your hypertensive individuals. Stay tuned. Thank you very much for coming. Thanks to the panel and enjoy EuroPCR.